Hey Refam, my name's Kate and welcome back to Keeping It Real, the podcast that still wants to put you to sleep. This week I'm joined for part 2 in our series with fantastic anaesthetist Dr. Arturo Gomez. If you haven't listened to part 1, stop right now and check that one out first. In this episode, Arturo takes us through his top tips and tricks for patients to prepare for anesthesia, what's different for patients who have chronic pain or diabetes, and he gives us his insight for patients' biggest fear, waking up during surgery. It's a great episode. I hope you love it. And as always, leave us a comment with whichever specialty you'd like to hear from next. I think when asking what people are kind of concerned about or want to know about, by far and away, the biggest concern is either waking up during surgery or not waking up at all.
Mm-hmm.
Have you ever experienced either of those scenarios? And what are you going to say to put people's minds at ease for that?
All right. So the first one, let's deal with waking up during surgery. Look, it's a real phenomenon. It's called awareness. It is not common. Before we talked about allergies, we said 1 in 10,000. So we said chance of 0.0001% that you'd get an allergy. With awareness, I would quote it between 1 in 7 to 1 in 8,000. So again, very, very, very little. So chance that you'll have it. So one person in the village kind of thing. It is usually related to some risk factors. So there are certain type of surgeries that are higher risk of awareness, and that is cesarean sections under general anesthetic, cardiac surgery, and trauma. Those are the big ones. And then anyone that has muscle relaxant has a risk of awareness. And the way we mitigate these is by monitoring all your vital signs during the operation, including we put a brain monitor that sort of adds to the safety of it, letting us know that you are properly asleep.
Mm-hmm.
So people first don't need to be afraid, because I know there's a few movies. There's a terrible one that I don't want anyone watching, that it's called Awake. It's just really bad movie.
Mm-hmm.
And misrepresents what happens in anesthesia a lot. Rest assured that it's not common, and we are very, very careful that is not the case. Probably one of the top things we look at is to make sure that you're asleep. So when someone's under anesthesia, every 5 minutes or so, we do a top to tail assessment of you. So I look at your airway, I make sure it's working, I look at your oxygen, I look at your blood pressure, your heart rate, your rhythm, how deeply anesthetized you are. And in this case of anesthesia I administer, which is the intravenous one, which is got a tiny higher risk of awareness than the gas, I monitor that the place that it's going through, your arm or your hand, or it's running smoothly, it's not getting... So it's not something to worry about. That's one. And then not waking up is a very, very, very rare thing. Again, it's more related to the type of surgery.
Mm-hmm.
So things like neurosurgery, patients that have had a big trauma, patients that have been, in prolonged surgery that has been really intense kind of surgery, removing organs and things like that. We worry a little bit more, and that is very uncommon. Someone not waking up. But then there's another cohort that is slow to wake up. And yeah, that's not uncommon. And there are some risk factors, but it's not something we worry too much about. So those two things, if I was coming to an operation myself, I would have zero concern of. Zero.
The ones with slow to wake up, Richard's told a story before about a very cold lady. What do the patients, are they always brought to maybe not fully awake by their standard, but awake to you before they leave surgery?
Before I leave the hospital, I need to make sure that the patient is back to the fully functional capacity and ability from the brain, cardiovascular, and respiratory point of view. Of course, they're not going to be able to jump out of bed immediately and all that, but I want them to be able to be oriented, know where they are, be breathing on their own, and having the heart and blood pressure unsupported. And then no one would leave the hospital until that happens. Mm-hmm. Those instances of dodgy practices when it's not even a hospital and they've left a patient bleeding and exsanguinating, that will not happen in any scenario, because That's why it's being done by a surgeon and an anesthetist. That's something to be reassured. We've had a few patients that are a bit slow to wake up given the history and things. Not concerning. We had one lady, as you mentioned, that had a number of risk factors. One of them being sort of very cold, because that is one of the things, again, that we look after and sometimes when people are very skinny and have lost all the fat and all they have is skin and they're losing a lot of skin, they can get a bit cold. And this lady had a combination of things. So she had a long surgery in which she had a lot of skin removed. And she also had hypothyroidism. So her metabolism was a little bit slow. And so she didn't warm up very well towards the end of the operation. So it took a while. I was there all the time. And Richard, as a surgeon, I was there all the time and we were communicating our concerns. And after a while, she woke up properly. We had that brain monitor telling us that she was properly anesthetized and not in any kind of risk. And we were giving her oxygen all the time. But it's very uncommon. Like we've experienced that once in nearly 7 years we've worked together. I've experienced as an anesthetist being in practice for the last 15 years. Probably 3 patients behaving like that. And there is, again, like with the allergy and anaphylaxis, there is a sort of a series of processes and steps we take to determine why someone is not waking up. It's usually one of them is temperature, blood sugar, amount of medicines being administered and things like that. And then the last one, which people worry about, is having a stroke. Very rare, incredibly rare to have a stroke in the type of patients we do. Now, if you're talking about, a very frail elderly person having big surgery because they need some sort of therapy for a fracture or a bad pathology, then we concern a little bit more about mini strokes. But I don't know the number, but I would think it's probably about 1 in 100,000. Add another zero, so it will be 0.00001%.
Yeah.
So it's nothing. You're probably more likely within the next year to become a terrorist wanted by the ACO than to have a stroke.
How long does it typically take somebody to wake up?
With the type of anesthesia I administer, it's incredible. After 15 years of doing that, I still every time enjoy the way they wake up. And I'm surprised at how someone can be fully unconscious, unaware, and have big operations like we do here. As soon as they finish putting the dressings, I talk to them, they open their eyes, and I pull the breathing tube out, and they often just smile and give thumbs up, and they very often don't need oxygen to go to recovery. And maybe that's why I enjoy anesthesia so much. I still get surprised by this. I'm like, I know it's going to happen, but every time it happens, I'm like, wow, this is just amazing. Like, science is great, isn't it?
Somebody asked, does sedation carry a higher risk if you have hypertension or tachycardia?
Yes. Look. So here we don't do sedation because the operations we do at this practice usually just require general anesthetic. So sedation is like a step down from a general anesthetic in which you are a little bit asleep enough to not remember or be aware what's happening, but not enough asleep that you need intervention for your airway, and you're usually responsive. So we call that conscious sedation. Anyone having an operation or a general anesthetic that has past history of things like hypertension and diabetes and heart problems, of course, they have a tiny more risk. And that is in relation to the medicines they take. That is in relation to the damage the hypertension has done to your heart and your kidneys and your blood vessels, and also in relation to how much blood pressure your body is used to. So sometimes after you had a lot of blood pressure issues during your life, your brain and kidneys and all of your organs are used to a higher amount of pressure to deliver the oxygen and the blood to them. But the thing is, we also take that into consideration. So if you have high blood pressure or diabetes, all we really need to do is have a chat, tell you which drugs to not take, which ones to take, and the intraoperative part of it, you leave it with me. I'll make sure that we are delivering the amount right of pressure, and it's equally safe. So we talked about ASA 1, which is you have no disease. And then this patient would fall into an ASA 2. which means they have mild control disease that is not a risk to life. So for all terms and purposes, they're fine to go to surgery, and you should not be worried at all.
What does the scale go to?
It goes up to 6.
Mm.
You don't want to know what 5 and 6 is, but 1 is perfectly healthy with no conditions. 2 is you have issues like diabetes or hypertension, but they have been looked on by a doctor, they have been treated, and they're stable. 3 would be someone that has lots of problems, and those problems are not necessarily stable. Let's go again to the example of the hypertension. If you have hypertension and diabetes, but you're also morbidly obese, smoke, and have sleep apnea, but have not stopped smoking, and you have not treated your sleep apnea, I would catalog you as a 3, because some of those can be a risk to your life, independent of the anesthesia. 4 would be someone that is really, really sick, and usually is sick, and it's having an operation with which, if they don't have it, they might die as a result. So a 4 would be someone that's had a heart attack, and they've determined that they cannot treat it with stents, and now needs an open heart operation.
Right.
Or someone that has severe cancer, and it's affecting their organs, and there's nothing you can do to treat that, and now they need an intervention to treat one of the problems that's generated. So it's a very different category, and those patients are very sick. 5 would be, if you want me to tell you,
Yeah, please.
would be someone that it's not expected to survive despite the operation. That's sick. And 6 would be someone that is donating the organs.
Oh, I was going to say already dead.
Yes, correct. That sort of classification. Of course, this is useless to patients if I tell you you're 1 or 2 or 3. So I explain, and this is not the case with the patients we do here. We've done a couple over the years that have conditions, and we've mitigated the risk by making sure it's stable. And if we thought they were not stable, as in their ASA 3, we'd probably not go ahead.
Yeah.
And we've had a couple that have come, a couple of patients that have come to the practice and wanted an operation, and they've been discussed by the surgeon and myself, and we said, look, it's in your best interest to not have an operation, because we think the risk outweighs the benefit, and we would not be willing to put you through that for you to have a bad outcome to your health. And I often explain to patients, again, not in this practice because it's not the type of patient. It's like if you're flying from here to Sydney, in a brand new A320 with a clearly smart pilot, and it's a sunny day, well, you're going to have no issues. You're going to arrive, no bumps in the air. Landing and taking off is going to be smooth. Now, if you're flying on a 1970s Cessna, which has had, the engine repaired a number of times, on top of that, it's a bit rainy and stormy, and the pilot's a bit tired and not quite up to date with, well, of course, it's going to be bumpy and dangerous. And so most of the patients we do here are new A320s with a smart, clearly headed pilot. So you'll be fine.
Level 3 is when they're a Boeing and I can come out of the sky. And
well, Boeing is a whole different category, Kate.
It's a 5.
I don't know if you would you fly on a Boeing?
They booked flights to Europe, and I was like, I wonder if any of them are a Boeing, but I think I'm okay. Some patients are worried about long-term effects. How likely are they?
The medicines we use for the anesthesia itself are very reversible, and they go away very quickly. So within 24 hours, you shouldn't have any effects from the anesthetic. We do send you home with pain relief, and sometimes that pain relief can make you feel a bit funny. Some of the medicines we give you can give you a bit of double vision. Some of the medicines we give you can make you sleepy and give you funny dreams and make you feel a bit euphoric, as in having a high, but nothing long term. People get concerned. People sometimes tell you, oh, look, after I had the anesthesia, I've not been the same. I can 100% reassure you that is not the case in the type of patients we do. Again, there is a known complication called post-operative delirium, and now we know that is associated with mini strokes in old people. And that is in relation to the blood pressure management. So not the case, not applicable for patients that we do in this practice.
Some people are also worried about, that extreme pain once they wake up, that everything's going to come flooding in. You've obviously talked about the fact that there's pain relief administered after as well as during. For our patient profile, is severe pain a common thing?
Oh, no, look. So the operations we do here are often quite big and require a lot of pain relief. But that's another part of our job, is to make sure that the pain you are going to feel is manageable. Management of expectations is really important. Any patient coming to have big surgery needs to understand that they are going to have pain. Our role is to keep you in a nice spot where you will have pain, but the pain will not be excruciating. Some people want to have no pain, and that's unrealistic, because for you to have no pain, we would have to have you completely drugged up, and that will harm you in many ways. So there's a few risks. We actually do worry a lot about patients after surgery. One of them is having blood clots because they're not moving around. And the other one is having chest infections and pneumonia. Statistically speaking, those are the two things that are most likely going to harm you if we don't look after them after an operation. So the way we look after that is making sure you're not completely obtunded, pushing you to get out of bed and walk and regain some form of activity. In order for us to do this, we have to not have you completely asleep, but not have you in agony that you cannot move. People often speak about a scale of pain, which I don't particularly like. They say 0 to 10, what is the worst pain in your life? But if we were to apply that scale, we aim to have you at a 4 or a 5. If you have never experienced pain and you are not a chronic pain patient. We have done a couple of chronic pain patients. We have successfully tailored a plan for them to be able to go through the surgery and use special medications. And these patients, we explain, they come to tell you the baseline pain is 6. And your idea is to have them around 6 or 7. But if you're a normal person with no chronic pain history, you do need to expect that you're going to have a 4 out of 5, meaning that you're going to be able to just gently roll on bed, start reaching for things, and then the day after surgery, get out of bed, have a little walk to the toilet, sit down on the chair, then progressively start moving. But definitely painless surgery will not happen.
I know the scale is interesting. I freak out like I have to pass this test with the right answer. But I'm always like, I don't know, like what's a 10? Like what are we talking? My 10 or like the 10,
Correct.
But that's something I'm working on mentally. Is there anything that patients can do before a surgery to ensure that it's the most seamless, safe operation they can do anesthetic-wise?
Absolutely. That's a big part of anesthesia research these days. Is called prehabilitation, encouraging to do little changes and big changes. One of them would be, if you smoke, you need to stop smoking. Stop smoking before surgery. Even if you just quit 2 weeks before surgery, that brings a lot of benefits for your recovery, for the wound healing, for the infection risk, for the lung complications, and for your heart and blood vessels and blood pressure type of complication. So stop smoking is the first thing you need. Once you decide you want to have surgery, I would say your priority, if you smoke, is to stop. Patients that have come to us because they have lost a lot of weight and they're in the process of losing more, definitely should keep doing that and not gain weight. So that is the other one. And then the third one I would say is look after your nutrition and exercise. People that exercise at least 3 times a week and keep their fitness level at a good level tend to recover much quicker. Then the fourth one, and this is just a personal one I would recommend, is exercise the groups of muscles that you're going to need to use after an operation. Think about transferring from bed to chair. Think about walking. Make sure you exercise your quadriceps, your biceps, make sure you've got some core strength. So perhaps do a little bit of gym work about a month before surgery. Don't go crazy. This is not like you're not trying to get, like ripped. Just exercise the groups of muscles. And then in an ideal world, you would do something we call inspiratory muscle training, which is to breathe in against resistance. There are devices for these. And if you do 10 of these in the morning, 10 of those at night, that's brilliant. Your lung function around the surgery will thank you for that a lot. But that's in an ideal world, and things to come with that. We'll see.
Thank you very much. It was so interesting and informative. If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.